and hopefully a few more people will join us. But for today, we have Dr. Jasudian here, who's going to be doing a presentation on hepatic encephalopathy. So I will go ahead and turn that over to him.
Great, thank you. Thank you all who are attending today. I'm Dr. Jasudian, and I'm one of the hepatologists. And if you see Dr. Brown or Dr. Lucero, Dr. Rosenblatt, Dr. Fortune, I'm one of their partners. And today's topic is an important one for patients who have problems with liver disease and cirrhosis. They might develop this condition called hepatic encephalopathy, which is a bit of a mouthful, but it really is a condition that affects the brain, but it's related to cirrhosis. And we'll talk about why that happens. And of course, at the end, I'll be happy to answer any questions from you. So I wanted to start by making sure everyone understands what cirrhosis really is. Anything that causes inflammation or damage in your liver will eventually lead to liver scarring. And cirrhosis is kind of the final stage of scarring of your liver. And we think that it's generally not reversible once you get to that point. And again, any process that damages your liver can lead to cirrhosis. And some common causes of cirrhosis include fatty liver or non-alcoholic fatty liver disease, hepatitis viruses like hepatitis B and C, drinking too much alcohol, autoimmune problems. Some people have an inherited or genetic problem that leads to their cirrhosis. There are many different causes of it, but the end result is the same, a liver that has been replaced in large part by scar tissue, and that's what cirrhosis is. Some people have cirrhosis and they don't have any symptoms from it, or even their blood work might not look that abnormal, but at some point, if the cirrhosis gets worse, people will develop symptoms, complications of their cirrhosis, and when that happens, that's when your liver has become overwhelmed, and that's usually when we would start the process of evaluating someone for a liver transplant. This picture here on the right is a microscopic picture of a liver that has cirrhosis. This pinkish color is normal liver, but all this bluish, light blue, aqua colored stuff is not normal. That is scar tissue. And when cirrhosis is there, the scar tissue forms nodules, and a cirrhosis liver can have a lot of lumps and bumps to it, whereas a normal liver would be smooth. The complications of cirrhosis that we most commonly see are ascites. Ascites is fluid that builds up in your belly or abdomen. Hepatic encephalopathy, which we're going to talk about in detail right now, and variceal bleeding. Variceal bleeding is a type of internal or gastrointestinal bleeding that happens when dilated veins in your esophagus or stomach get large enough to rupture or open and cause bleeding. That is also related to cirrhosis. When someone has developed ascites or hepatic encephalopathy or variceal bleeding or more than one of those, we consider them as being decompensated. Their cirrhosis is now more advanced, and again, that's when we would talk about the need for a liver transplant. So what is hepatic encephalopathy? And I might say HE for short during the course of this talk. So this is a complication of liver cirrhosis. Importantly, it's reversible. It can affect your brain both neurologically and psychologically or psychiatrically, but after your liver goes back to normal with a transplant, it should generally go away. Or if you take appropriate treatment for this condition, those symptoms can go away. There are a whole spectrum of symptoms, and they can be very mild all the way up to being very serious when someone is in the hospital in a coma because of hepatic encephalopathy. Now, why does this happen when you have liver cirrhosis? This starts in our large intestine or colon. And in the large intestine, we have tons and tons of bacteria that live there normally. And when we eat proteins, they get broken down by bacteria. And one of the byproducts of that is ammonia. Ammonia normally would travel through the blood from the intestines to the liver to be filtered out. Your liver, among its many, many jobs, is to detoxify or remove ammonia from the bloodstream so that ammonia is not in the blood that goes up to your brain. But what happens in the setting of cirrhosis is that your liver is sick. It's not doing its job as well as it normally does. And that allows ammonia to travel in the blood to the brain, and it causes a little bit of swelling of some of your brain cells, and that will then cause the symptoms of hepatic encephalopathy. So it starts with bacteria in our colon, large intestine, but at the end of it, it's an ammonia affecting your brain problem. And it all is allowed to happen in the setting of cirrhosis, significant liver damage. Now, as your doctors, we can talk about how severe hepatic encephalopathy is. And there are some scoring or grading systems. This is one of the most commonly used ones. And it goes from a grade of 0, where you're completely normal, you don't have any hepatic encephalopathy, all the way up to grade 4, which is the most severe. This is someone who's very sick in an intensive care unit because they're in a coma related to the large amount of ammonia affecting their brain. In the middle, we have grades 1, 2, and 3. And you might find some of these symptoms familiar as we talk about them. If you've experienced it or your loved one has, grade 1 is more subtle. And what I usually say is that the effect of ammonia on the brain is similar to a depressant type effect that you might experience if you took like a benzodiazepine, if you're familiar with, say, Valium or Ativan, or even the way alcohol can affect your brain. So early on, ammonia will cause some subtle symptoms, like you're less aware of your surroundings. You can become anxious or even euphoric, not able to pay attention as well as you normally do, and you might develop a characteristic flapping tremor called asterixis. Asterixis is when we ask you to put your hands up like you're stopping traffic and we cease flapping. That's related to the ammonia hepatic encephalopathy problem. As we get into grade 2, patients can be more lethargic, meaning they're falling asleep. They can lose their orientation. Maybe they don't know exactly what the date is or where they are. We can see some personality changes, even some slurring of speech, because again, the effect on the brain is similar to something like alcohol. And we definitely see asterixis, the flapping tremor. Into grade 3, these are the patients who are close to being in that coma, but not quite there. But they could be falling asleep almost in a stupor, completely confused, don't know where they are, behaving bizarrely. So ammonia can do all of this, but it is fortunately reversible. Here we see the stages of hepatic encephalopathy going from left to right, where we're talking about normal, stage 1, 2, 3, and 4. And you see all the different parts of your brain function that can be impacted by hepatic encephalopathy, by this ammonia problem. So how conscious you are, what your intellectual function is, so what's your attention span like, personality behavior, so kind of psychiatric or psychological symptoms, and also neuromuscular, meaning ammonia, if there's a lot of it affecting your brain, can make you move more slowly, talk more slowly, slur your speech. And all of this gets worse as the severity of hepatic encephalopathy gets worse. One thing we found about found out about relatively recently is minimal hepatic encephalopathy. These are people who don't even have that grade 1 hepatic encephalopathy, but we find out that they're actually somewhat impaired if we test them with advanced cognitive testing. Why this is important is that we've come to find out that in patients who have cirrhosis, a very large percentage of them, up to 80%, have some level of hepatic encephalopathy, even if it's minimal. So if you have cirrhosis and you don't have the really obvious hepatic encephalopathy, ammonia could still be affecting your brain in ways that we could detect if we tested for it. Those who have this minimal hepatic encephalopathy are at risk for progressing to overt or obvious hepatic encephalopathy. And we know that these patients with minimal hepatic encephalopathy, although they may appear to you to be pretty much at their baseline, how they normally are, that their quality of life can be lower because of this. Their ability to work could be less than it normally is because their brain is not functioning 100% like it used to. And one thing that is very important to talk about is that even with minimal hepatic encephalopathy, but definitely with overt or obvious hepatic encephalopathy, the ability to drive safely is impaired. And that's because this ammonia on the brain is similar to drinking alcohol, and your reaction time could be slow. If you decide to, say, turn the wheel to avoid something in the road, your muscles will move more slowly, and you might have trouble even navigating or remember where you're going. So it's important to know that if you have a diagnosis of hepatic encephalopathy, even minimal hepatic encephalopathy, you should talk to your doctor about whether it's safe to drive. And we know from many studies that it's usually not if ammonia is affecting your brain. What's the big picture, the burden of hepatic encephalopathy? Well, we're seeing over the years more and more hospital admissions for hepatic encephalopathy. You see this increase through 2010 on this slide, and that has continued to increase over the past 10 years. The reason is that more and more patients are getting cirrhosis and liver disease, in part because fatty liver problems, a liver problem related to being overweight or obese or having diabetes, high cholesterol, is something that's kind of exploding in our country. We're seeing more and more and more of it. In part because we are getting better at treating cirrhosis, so people might not be dying of it as often as they used to, but they still require being in the hospital if they develop certain major complications of cirrhosis. And hepatic encephalopathy is one of the most common reasons for someone with cirrhosis to have to go to the hospital. If you're confused, then we do need to check you out and figure out what might have caused you to be more confused, get you on the right medicines to lower that ammonia, and that requires hospitalization. The other burden of hepatic encephalopathy is on the patient themselves. What we know is that hepatic encephalopathy, when you develop it, means that your liver is quite sick, and your chance of surviving long-term without a liver transplant is not high if you have hepatic encephalopathy. So less than half of people who have developed hepatic encephalopathy are alive 1 year after that diagnosis, and less than 1 out of 4 of them are alive at 3 years, and this is, of course, without a liver transplant. The patient and the family can also be burdened by this condition. So patients who have hepatic encephalopathy, because it is a brain condition, can find that they're not able to work. They might have to decrease their hours or stop working altogether, which means that they're bringing in less income to the household. Most patients up to 90% who have had obvious or overt hepatic encephalopathy are not able to work at all, whereas most cirrhosis patients who have never had hepatic encephalopathy are still working. The majority, over half, report decrease in work hours. When hepatic encephalopathy can be a big challenge to the caregivers who are watching out for the patient who has hepatic encephalopathy. It can be pretty similar to someone who's taking care of an elderly relative who has dementia, because they have to worry about, are they taking their medicines? Might they fall? Might they leave the stove on? And so a caregiver has to become very involved when a patient has hepatic encephalopathy, but that can cause disruption to their own life, and it can cause a lot of psychological stress or even sense of entrapment. And if you are feeling any of that, I encourage you to reach out to the social worker assigned to your case and see how they can assist in you coping with that situation. This slide says what precipitates HE or hepatic encephalopathy. This is an important concept, particularly when we're teaching young doctors how to take care of someone with cirrhosis and hepatic encephalopathy. So let's say I have a patient with hepatic encephalopathy who's been doing pretty well on their medications, and I get a call saying that they are all of a sudden very confused and disoriented, and I'll say, bring them to the emergency room. The reason is that when someone suddenly becomes worse with hepatic encephalopathy, we need to think about what going on in their body precipitated or caused this to happen. And a lot of these possibilities are major problems that we need to treat quickly and in the hospital. Things like bleeding from those varices or somewhere else in your intestinal tract. Things like infections, pneumonias, urinary tract infections, infections in the ascites fluid in your abdomen, bacteria that end up in your bloodstream. It could be that you are taking sedating medicines, sleep medicines, pain medicines. There could be a kidney or electrolyte problem. And there could be an issue with not having enough bowel movement. And we'll talk about why bowel movements are important. But in general, having bowel movements is very important for patients with hepatic encephalopathy because it means you're eliminating or getting rid of bacteria in your colon so they're no longer around to generate the ammonia that causes the symptoms of hepatic encephalopathy. So that brings us to how do we treat hepatic encephalopathy? First and foremost, we need to treat the precipitating cause. So if it is a bleeding problem, we need to figure out where it's coming from and stop it. If it's an infection, we need to start antibiotics. If it's an electrolyte problem, we need to address that. But then we have medications that we give in order to lower this ammonia in your system and make your symptoms better. In general, these medications are going to work at the level of your colon or large intestine to get rid of bacteria there, because bacteria are the ones creating all this ammonia. The two most common medications we use are lactulose and Xifaxan, which starts with an X, and the generic name of Xifaxan is rifaximin. Lactulose, if you've ever taken it, you'll never forget it because it tastes very sweet. It's a type of syrupy liquid that you take, and it's a type of laxative that'll make you have bowel movement. The reason we give it to patients with hepatic encephalopathy is that by having those bowel movements, you get rid of bacteria, so less ammonia, but also lactulose can change the pH balance of your large intestine and make the ammonia harder for your brain to absorb. And those two actions together help treat your symptoms of hepatic encephalopathy. Xifaxan or rifaximin is a pill that we give twice a day. It helps lactulose work by killing bacteria in your intestine. It usually does not get into your bloodstream. It's mainly in your intestine. So it's an antibiotic that we can give long term. Unlike an antibiotic you might take for an infection, like a urinary tract infection, this is not one that you only take for 7 or 10 or 14 days. Xifaxan for hepatic encephalopathy you take every day until usually your liver transplant. Lactulose is a tricky medication to take, and that's because there's no one correct dose for everybody. What your doctor usually tells you is take as much lactulose as your body needs to have 2 or 3 soft bowel movements a day. We want you having more than one bowel movement because we need to get rid of bacteria, but we don't want you running to the bathroom 10 times a day because we don't want you to be too dehydrated. So that is the right amount of bowel movements to have, 2 to 3 soft bowel movements a day. There's no real overdose from taking too much lactulose apart from diarrhea, and diarrhea can make you dehydrated, which can actually make your hepatic encephalopathy worse. Although lactulose tastes very sweet, it actually does not raise your blood sugar. It doesn't get absorbed into your blood. So it's okay to take even if you have diabetes. What we normally say is that if one day you or the person you're caring for is foggier in their brain, they're a little bit more confused, the first thing we'd suggest is give some additional lactulose until they have 1 or 2 bowel movements and see if that clears up their mental status. Compliance, meaning whether you take it or not and whether you take it the proper way, is really important to lactulose working well. Skipping doses, getting constipated, not having enough bowel movements, that can all lead to hepatic encephalopathy getting worse and could very well lead to you needing to come into the hospital. So what about Xifaxan or rifaximin? This is again added to lactulose to help kill bacteria in the colon. We know from clinical studies that have been done, if you take Xifaxan and lactulose together, you have a better chance of staying out of the hospital, not needing to come in for an episode of hepatic encephalopathy. We usually give them together, but on occasion, if someone can't tolerate lactulose, they might take Xifaxan or rifaximin by itself. It's a twice-a-day pill, and again, it doesn't get into your bloodstream, it just kills bacteria in your intestine, and generally it's very safe and well tolerated. We have very few patients who cannot take Xifaxan. A common question that comes up is, should I limit the amount of protein I eat? And the reason people ask that is that we know that bacteria breaking down protein make the ammonia. In the old days, they used to say, if you have hepatic encephalopathy, eat less protein because that's less ammonia. We found out over time that's actually really bad advice. So in general, we do not tell our patients to limit the amount of protein you eat because having cirrhosis is a condition that causes you to become malnourished and causes your muscles to get smaller and break down. And we want you to remain strong, particularly if you're going to get a liver transplant. So nutrition, including protein, is important to offset those muscle losses. Now what happens, and we didn't realize in the olden days, is that if you don't eat enough protein, more of your muscle is going to break down, and ammonia comes from your muscle tissue as well. So your hepatic encephalopathy is not going to get any better if you're limiting the amount of protein you eat. It might get better if you're eating a good amount of protein to offset your muscle loss. Very common to not have a good appetite when you have cirrhosis or to feel full after eating just a little bit. And that's okay. I would just focus on eating small, frequent meals in that situation so you're getting in enough calories, enough protein to maintain your strength and your muscle mass. Those patients who go in with better muscle mass, better nutrition into their transplant recover much more quickly than the ones who do not. So in summary, Hepatic encephalopathy is a very serious complication of cirrhosis, and it can impact how long you survive and what your quality of life is like during that period of time. And in your case, if you're looking at a liver transplant, then during that period of time while you're waiting for the liver. Hepatic encephalopathy will be completely cured by the transplant, completely reversible. The effect of ammonia on the brain will go away. Your priority for getting the transplant, unfortunately, does not get impacted by whether or not you have hepatic encephalopathy. That really depends on your blood tests, your MELD score. Hepatic encephalopathy is a disease that can infect the entire family. Compliance or taking your medications the way they're prescribed is key, is very important. If you or your family member is suddenly more confused or lethargic, call us or go directly to the emergency room. The reason being that those precipitating causes can be real emergencies, bleeding, infections, kidney problems, and we want to evaluate you for all of that and address it so that we can get you home and hopefully stay there on the medications that prevent you from getting bad hepatic encephalopathy episodes. So that is the end of that presentation, but please let me know if you have any questions.